All right, let's dive into one of the most lethal partnerships in all of medicine, HIV and tuberculosis. In this explainer, we're going to break down absolutely everything you need to crush your exams and excel in your clinical practice. We'll take this incredibly complex topic and turn it into a clear, logical framework you can actually use.
So why is this such a big deal? Just look at this number, 25%. Nearly a quarter of all deaths among people living with HIV are caused by tuberculosis. This isn't just some random comorbidity. It is the single biggest killer. Understanding this deadly interaction is non-negotiable.
So here's our game plan. First, we'll unpack the vicious pathogenic cycle. Then, we'll get into the tricky clinical presentations, how to diagnose it with modern tools, and the super complex strategy for treatment. After that, we'll tackle the infamous complication called iris, and finally, wrap it all up into a perfect exam answer for you.
Okay, let's start right at the very beginning, at the foundation. If you want to master HIV TB, you have to understand the immunopathogenesis. Seriously, everything else, the clinical signs, the diagnostic puzzles, the treatment choices, it all flows from this deadly synergy.
Here's the textbook definition, but I want you to focus on that key phrase, accelerating the progression of the other. This is so important. This isn't just two separate diseases happening to be in the same person. No, they are actively fueling each other, creating this devastating feedback loop. So let's break down exactly how that happens.
Think of this as a two-way street of destruction. On one side, you have HIV, which is systematically taking apart the immune system. It goes straight for the CD4 plus T cells, the generals of your anti-TB army. When they're gone, the granulomas, which are like little biological prisons your body builds to contain TB, they just crumble. But it gets worse. On the other side, the TB infection itself creates this constant, generalized immune activation. And for HIV, that's like pouring gasoline on a fire. It gives the virus a ton of activated T cells to infect, which just cranks up HIV replication.
This diagram shows that process perfectly, and you should be able to sketch this out in an exam. So in a healthy person, you have a nice, stable granuloma keeping latent TB locked down. But then, HIV gets into the picture. It infects the very cells that are supposed to be guarding that prison wall. As HIV kills off the CD4 T cells inside, the whole structure just falls apart. The TB bacteria escape, reactivate, and then spread all over the body.
So now that we know how it happens, let's talk about what it looks like in a patient. Because HIV has crippled the immune response, TB doesn't play by the rules anymore. It doesn't give you that classic textbook picture. Instead, it becomes what we call a great masquerader, which can lead to misdiagnoses and frankly terrible outcomes.
This table is absolute gold for your exams. In a normal, immunocompetent person, you expect to see a positive sputum smear and those classic cavitary lesions in the upper lobes of the lungs on an X-ray, right? But in someone with advanced HIV, you can just throw that out the window. The sputum smear is very often negative because the body just can't mount a strong enough inflammatory response to get enough bacteria into the sputum. We call that paucibacillary disease. And you won't see cavities because the immune system is too weak to even form them. Instead, you get these diffuse infiltrates and massive lymph nodes. And get this, more than half of the cases will be outside the lungs entirely.
And you know what the single best predictor of all this is? The CD4 count. If that count is above 200, the patient still has enough of an immune system to give you a classic TB picture. Upper lobe infiltrates, maybe some cavitation. But once that count drops below 200, the whole game changes. The presentation starts to look like primary TB in a little kid. You see massive lymph nodes in the chest, disseminated disease, and those frustrating smear-negative results. The CD4 count truly dictates everything you're going to see.
Okay, so these atypical presentations obviously make diagnosis a huge challenge. If you're relying on old-school methods, you are going to miss it, and that could be a disaster. So this next part is all about the modern tools we have that help us see through this diagnostic fog.
And this is exactly why we've moved on from traditional methods. Sputum smear microscopy, its sensitivity in this population is only about 50%. That's a coin flip. It's because of that paucibacillary state we talked about. But now, we have the CBNAT, which stands for Cartridge-Based Nucleic Acid Amplification Test. This thing is a total game changer. It doesn't look for whole bacteria, it looks for bacterial DNA. So its sensitivity shoots up, you get a result in under 2 hours, and, this is huge, it tells you right away if the TB is resistant to rifampicin. It is the absolute standard of care.
We've got other tools in the toolbox too. For our sickest patients, the ones who are severely immunocompromised with a CD4 count under 100,
The urine LAM assay is incredibly valuable. It detects a TB antigen in the urine, which basically tells you the disease has spread everywhere. Of course, culture is still the gold standard for full drug testing, but man, is it slow. The real key here is a multi-pronged approach that's tailored to just how sick your patient is.
All right, so you've made the diagnosis. Now comes the next major challenge, managing the treatment. And this is so much more than just treating TB. You're basically fighting a two-front war. You have to balance two powerful drug regimens. You have to manage all the interactions, and you have to get the timing absolutely perfect.
Okay, I need everyone to listen very closely to this slide. This is a guaranteed exam question. The timing of when you start antiretroviral therapy, or ART, is completely dictated by the CD4 count. For patients with profound immunosuppression, a CD4 below 50, you have to start ART within 2 weeks of starting their antituberculous therapy, or ATT. The reason is simple. Their risk of dying from another AIDS-defining illness is far greater than the risk of IRIS. For patients with a CD4 over 50, you have a bit more wiggle room, between 2 and 8 weeks. And please remember the critical exception. For TB meningitis, you always delay ART for 8 weeks to prevent dangerous inflammation in the brain.
This algorithm really just pulls that whole management plan together into 5 clear steps. Step 1, you diagnose TB, you start ATT immediately. Don't wait. Step 2, get that CD4 count to know what you're dealing with. Step 3, time your ART initiation based on that number. Step 4, everyone gets cotrimoxazole prophylaxis. And Step 5, you watch them like a hawk for that paradoxical complication we're about to talk about, IRIS. Now, beyond just the timing, the other massive headache is drug interactions. Rifampicin, which is a cornerstone of TB treatment, is a really potent inducer of the cytochrome P450 enzyme system in the liver. In plain English, that means it makes the liver chew up other drugs way too fast, especially the protease inhibitors used in ART, making them basically useless. So the solution is either to build an ART regimen around a drug like efavirenz, which isn't affected as much, or you have to swap out the rifampicin for a less potent drug, Refabute.
Okay, now for a really fascinating and often scary complication. Immune reconstitution inflammatory syndrome, or IRIS. This is what happens when you start ART. The immune system roars back to life, and it suddenly sees this huge load of TB antigens everywhere. And what does it do? It launches a massive, over-the-top inflammatory attack.
What's so crucial to understand is that IRIS is not a sign of treatment failure. It's actually the opposite. It's a sign of immune recovery. The patient's immune system is finally waking up and starting to fight. But that awakening can cause this dramatic and sometimes pretty dangerous worsening of their symptoms. And IRIS really comes in 2 main flavors. The most common is paradoxical IRIS. This is when a patient is already diagnosed with TB, they're on treatment, but after you start their ART, their symptoms get way worse. Their brand new immune system is just overreacting to all the dead and dying bacteria. The other type is unmasking IRIS. This is when a patient starts ART and then all of a sudden develops symptoms of TB for the very first time. The recovering immune system has just unmasked a hidden subclinical infection that was flying under the radar.
So how do we handle it? Well, first things first, you have to rule out other problems like drug resistance or a brand new infection. Then, and this is the most important point, I really want you to hear this, you continue both the ATT and the ART in almost every single case. Stopping therapy is the wrong move. You treat the inflammation with things like NSAIDs, and for the really severe, life-threatening cases, you bring out the big guns, corticosteroids like prednisone to calm that immune response down.
We've covered a ton of ground. Now let's pull all these core concepts together and structure this knowledge into the perfect format for your exams. I want to make sure you can walk in there and deliver a comprehensive, high-scoring answer, even under pressure. Here it is. This is the blueprint for a perfect 10-mark essay answer, and it follows the exact flow of our discussion today. You start with the definition and the burden. You explain the vicious cycle of pathogenesis. You detail the clinical features, always linking them back to the CD4 count. You outline the modern diagnostic algorithm. You detail the management, making sure to highlight ART timing. You define and explain IRIS. Then you wrap it up with a conclusion about the challenges of co-management. If you follow this structure, you'll be in great shape.
Okay, let's put that knowledge to the test. Here's a classic Viva question. You have a patient with a CD4 count of 40 who's just been diagnosed with pulmonary TB. When are you starting ART, and more importantly, why? The answer you give is, ART should be started within 2 weeks of initiating ATT. The reason is that in severe immunosuppression, the risk of death from another opportunistic infection is much higher than the risk of developing IRIS.
And let's do one more. Why is the sputum smear so often negative in these very sick patients? The answer is,
It's because their cell-mediated immune response is too weak. They can't form effective granulomas or cavitary lesions. This leads to a much lower number of bacteria in their sputum, a condition we call possibacillary disease, and it just falls below the limit of what a microscope can detect. It's not that the bacteria aren't there, it's that the body can't fight them hard enough to show up on the test.